Hi, good afternoon. I'm Greg James, and I'm just making sure that you can hear me in the back. I think I can hear myself in the back. And also, I just asked for slides to be advanced, correct? Okay. First of all, I wanted to bring greetings on behalf of my boss, the Chief Medical Officer for Optum Care, Dr. Ron Schumacher. I think many of you know him. Trust me, he would rather be here as much as he likes his bosses and his bosses' bosses to the very top of United. That's where he's been at a conference. So, plus it's in Minneapolis versus Washington. But thank you very much for the invitation. We appreciate it. Next slide. Next. I'm going to talk just a minute about, I think many of you, most of you have heard of United Health Group, United Health Care, and many of you have heard of Optum, but the Optum Care division and where we sit within this big publicly traded company. United Health Group is actually listed as one of your sponsors. It's UNH, it's traded on the New York Stock Exchange, has two divisions. United Health Care sells the insurance, pays the doctors, credentials the doctors. Basically, they're the health benefits division of our company. Optum, where we sit, are the health services. So we help to take care of the patients that have United Health Care and other carriers' insurance. Within Optum, there are three major divisions. Optim Health, where we sit, we're going to get to that. Optum Advisory Services recently changed its name when it entered into an agreement with the advisory board. They were Optum 360, they were Optum Insight. They're a data mining company that many other insurers buy the information from us. And then Optum Rx is our pharmacy benefits division. Next slide. So Optum itself, the company, this tells you a little bit about the company and all the different pharmacies and insurers and patients that we hit on an annual basis. Not hit, that's not a good word, that we interact with on an annual basis. Next slide. And then within Optum Health is Optum Care. What I'm going to focus in on more specifically is our complex care management in the upper right corner. That's our skilled nursing, post-acute and long-term care. But also within Optum Health, if you go to the left, care delivery, you heard somebody earlier talk about ProHealth. ProHealth is a part of Optum Care now. Also WellMed in Texas and in Florida, and Monarch and Apple. These are some of the services, care services parts of Optum. And then MedExpress, we're actually up, this slide is this year at 150. We're up to 200 centers now for urgent care and plan to be over 250 by next year. And house calls, somebody mentioned house calls. I don't think it was our division, but our house calls division does over 1 million in-home assessments every year as well. And we're looking to hopefully partner more with them in the future for our patients that actually go home from the nursing home in our transitions program. Next slide. I think many of you have seen this data as well, kind of focusing down into the potentially reavoidable admissions cost of $17 billion. This is a few years old, probably a little bit more right now, but as many as 20% of Medicare beneficiaries are readmitted to the hospital. So I know we've had incentives come in through the Affordable Care Act, but it's still not down where we want it to be. Some of the reasons that we go over in this slide are primary care physicians, and I am at heart family physician, geriatrics and nursing home followed those, but they're spending time in their office, even in the hospital, not enough time to get to the nursing home. That's where we come in that I'm going to explain. And 40% Medicare beneficiaries that leave a hospital, they go to a post-acute setting. Half of them to the nursing home, the other half either an acute rehab facility. Some of you know what Health South is, but they're inpatient rehab centers, assisted living, or even home health care counts as part of that. Next slide. So I'm going to talk about two different parts of Optum Care. The post-acute first. This is what we call the Transitions to SNF, TTS, Transitions to Skilled program, where we are sending in nurse practitioners to homes, working with the homes. Obviously, we're invited in to help out, but work with our patients that are Medicare Advantage beneficiaries of United Healthcare in the community, typically have had an MI or a broken hip, but they have the ability to go home. So they're there for a short-term stay. At the few end slides, I'm going to talk about our institutional special needs program. You've heard SNP or special needs program. I'm going to talk about that at the end, but those are our two different programs. These are just some data that we have, and we want to talk about the financing as well, obviously, but financing is woven through our model of care. And the way that we actually save money so that we can expand to other programs are by optimizing length of stay, by actually looking at the patients and making sure they're going home at the appropriate time. And we do that, one of the primary ways we do that is starting discharge planning on day one. If we start the discharge planning on day one, it's not that they're going home on day 2 or 3. They're still having an average length of stay of 17 to 20 days. But when they're ready to go, they can go. Traditionally, what's happened in the past, unfortunately, is patients would stay in the nursing home, and on the day that they're ready to go, they start the discharge planning. Well, then it takes as much as a week to get the doctor's appointments, the scripts, a home assessment. Are they even ready? Are they even able to go home? And we also know that 5 to 10%, depending on the area, actually wind up in long-term care. So we help with that transition as well. And then one of the most important things that we do is reduce the readmissions, or reduce the readmission rate. And I, as a physician, have never looked at readmission rate as a number. I've looked at it as how well are we taking care of the patient. Because there aren't very many patients, there are some, but I'd say it's a minority, that wake up in the morning and say, I want to go back to the hospital. That's not what happens. What happens is that we may have missed something 2 hours, 2 days, or 2 weeks ago that if we had addressed it, would have prevented that admission. So it's also an early change in condition exploration that we're doing as well. Next. And this is just another program where we had also reduction in length of stay and also reduction in readmission rate. The other thing about the transitions program is that we're assisting that Medicare Advantage plan in closing some quality gaps. You've heard about that. Optimizing their documentation and coding. Remember, they're in a Medicare Advantage plan, so we're paid based on how sick they are on a per member per month basis. We're not paid based on how much we do to them or how many times we see them or how many procedures that we do. So we want to make sure that we're coding. And many times, these patients haven't seen their doctor, even though they're in the Medicare Advantage plan. That doctor doesn't make house calls. So this is the chance to get some of that coding done. And most importantly, as part of that discharge plan, is make sure they have an appointment to see the doctor, but also make sure they have a way to get there. And we're also partnering with programs such as Walgreens, CVS, where we can actually get them their medications delivered before they leave the home. Because as a physician, unfortunately, it was very sobering to find out that as many as 40 to 50% of the scripts that I wrote never got filled. Never. And of course, if you give them the prescriptions and you go over them with them and you make sure they don't have a duplicate or another beta blocker, it's also going to help you as well. Next slide. This is just a pro forma. Again, you're going to have these slides, so we want to save a lot of time for questions and answers. But if you took a pool of 100 patients and you reduce the readmissions by 20%, reduce the length of stay by 20%. We generally do better in both, so this was a conservative estimate. You can see the kind of savings that we have, and also with that, talking about the financing, where we're saving money, we're able to expand this and hire more nurse practitioners, go into more homes, and that's the plan. At the same time, we are improving quality by closing gaps. We're improving patient satisfaction because our nurse practitioners get to do some things that docs, like myself when I was in practice, and my nurse practitioner or my residents when I was training residents never had time to do. Spend the hour that you needed to spend on advanced care planning, not asking, do you want to be a DNR or not? Are you going to have the time to go through all the different facets of advanced care planning in the states that have it, POLST or MOLST? It's very, very important. And then, again, the readmission rate. Next. So this is just a single snapshot of what we do. Once the APC, the nurse practitioner or PA, is notified, they'll see the patient within 24 hours. And if they can see the patient on the same day, they do. We do have some information, not in a study, but just anecdotally, that the earlier that we saw the patient, even down to how many hours in the day after they got there, the sooner that we were able to see them, the less likely they were to go back to the hospital. And that started with actually helping with the medication reconciliation when they got to the facility. Starting discharge planning on day one. And then in the lower left, care coordination. Our nurse practitioners are not just care coordinators, they're case managers as well. Saving the step, being able to use the computer that's dialed in directly to United Healthcare or the other insurance company to override for certain high-cost medications, to make sure that we got a specialist paid to come in and see them. Whatever it was that they needed, getting that much more timely so that they didn't have to go back to the hospital or they didn't have to extend their stay in the nursing home. In general, patients heal better in their own beds, and that's where they want to be if possible, and if it's safe for them. And then, of course, ensuring the smooth transition back to their home, so that they're safe at home, they have what they need, they have the appointments, they have, you talked about it earlier, it was funny, I was talking with a couple of the panelists that I think just about everybody that talked this morning said something that is something that we do. We do the serious illness conversation with Ariadne as well. But the grab bars seems like a small thing, but most homes don't come with those. Surprise. So you got to make sure they do. You know what most homes do come with? Rugs that can slip out from underneath you. You know what most homes come with? Wires that shouldn't be where they are, including what several of us almost tripped over a wire here, and most of us aren't of nursing home age yet. So anyway, next. And these are just the focus areas of our transitions program. Again, starting with contact as fast as possible, collaboration with the various parts of the team, including therapy. I would be in a lot of trouble if I didn't mention therapy. Number one, it's extremely important. And number two, my wife is a physical therapist. Transition management, making sure that the transition to home is safe and smooth, and also quality of care. Closing those gaps, patient satisfaction is improved as well. Next. And this is just another snapshot. I'll skip that one next. All right, and so the special needs program, one of the biggest distinction about special needs program, and this is very timely, is that we're not held to that 6-week time period where you have to sign up for the program or whatever it is. It changes every year, it seems like. 8 weeks, 7 weeks, I think it ends December 7th. Our patients can sign up for the program any day of the year. These are long-term care patients that have Medicare A and B. The only exclusion is that they can't have an end-stage renal disease diagnosis. They cannot be on dialysis. Most of them have Medicaid, so some people think that that's a requirement. It's just that 80 to 90% have Medicaid, but it's not an absolute requirement. They can sign up any day of the year. They're effective the first of the next month. So the patients that are signing up today and tomorrow will be effective Friday. Those that sign up on Friday will be effective January 1st. So we're able to sign up patients every single day of the year. By the same token, if they want to disenroll, the disenrollment is effective the first of the next month. The only exception to that is if they sign up for hospice, they're effective that day on hospice or the day that they sign up. Next. So a little bit about the program. It's estimated that about 1.5 million Medicare beneficiaries are actually living in a skilled nursing facility, and that they spend about 2 times the average amount of their other beneficiaries. At least half have been to an ER and a third have been admitted at some time in their life. Again, that's twice what the average Medicare beneficiary is, but only 3% are in a special needs program. It is over 50,000 now. This is earlier in the year, because I know that we have 50,000 members in our program, but we have about 80% of the market on this. So what I'm saying here is there's a huge opportunity for the long-term care patients, Medicare patients in nursing homes to be a part of a program like this, or anybody that wants to file this type of institutional special needs program. Next slide. The high costs are driven by what we sometimes call a broken model. There are some areas more and more that have docs that are dedicated to SNFs. Some of them call them sniffists. That's all that they do, the geriatricians who only go to the nursing home. However, much of the care, if not most of the care, is still provided by primary care docs like myself that also had an office and a hospital practice. There's not necessarily good communication. There's not enough time to make the calls. There's not enough time to spend on the advanced care planning. And again, by supplying a nurse practitioner to the facility, we don't hire physicians, we hire nurse practitioners that go into the facility to work with the facility, with the doc's nurse practitioner or PA. They can improve that communication. They can coordinate the care. Again, it's something that even the practitioner that works for the doc doesn't have time to do. They've got to see 20 or 30 patients a day to make their salary. On average, ours are about half of that. It varies, but they don't work any less time. They spend twice as much time with the patient and often see them twice as often in the month. Next slide, please. So this program actually started out as Evercare. I might have started with that. Many of you have heard of that. United Healthcare owns the Evercare name, so when they moved us into the Optum division 3 or 4 years ago, that's where we became Optum Care. We are the #1 provider in this particular type of program, and this lists the number of nurse practitioners in Optum, the Optum Care program, but Optum United Health Group overall is the 2nd largest employer of nurse practitioners after the VA system. Big belief in making sure that if we can provide some mid-level practitioners to help the physicians, to help the facilities actually take better care of the patients at no cost to them, because it's Medicare Advantage. We never bill for our practitioners' visits. It's not going to interrupt any of their stream of visits or their income. Then we can help them in many other ways. And we're in about 1,300 nursing homes nationwide and growing every day. Next. That's the nurse practitioner, the care coordinator, the case manager, and you can see the Optum medical director, which is what I used to be in Florida before I came to the regional. We are not doing direct patient care. We are there as a resource, education for the practitioner. If they cannot get a hold of anybody else and want to review a case, and the other thing that we do is retrospectively review every case that goes out to the hospital, and we're looking for things that we missed. It's a quality improvement program, what I mentioned before. What did we miss 2 hours ago, 2 days ago, 2 weeks ago? Or what did the facility miss? When did they not call us that could have been helpful? Next. Just a little bit more, especially if you look at both columns on the patients that might be dual eligible. And I think that might be one more slide. Next. This is kind of the summary slide in terms of what we do for our members and reducing hospitalizations, ER visits by as much as 50% while improving patient satisfaction. Our voluntary disenrollment rate is less than 1%. And many of those are because they leave the nursing home. It's a nursing home only program, so they cannot have the program out in the community. Next slide. That's it. Thank you very much. Oh, by the way, I by design did not tell you to pull this out ahead of time, because otherwise you would not have heard a word I said. But these are in your programs to look at your convenience. It's more about Optum Care and where we sit. Thank you.